Up next, we delve into a topic that continues to shape surgical practice: excisional surgery versus ablative surgery for ovarian endometrioma. This is by Dr. S. Selva. Let us please welcome Dr. Selva. Over to you, sir.
Thank you. Again, let me thank the organization for inviting me to speak. It's always difficult to speak after a lecture on cancer. There's always a clash between reproductive surgeon whose job is to help the woman get pregnant and a cancer doctor whose job is to save the patient's life. So my job is today to try and make you think about other options for your patients with endometrioma. Now, when we look at ovarian endometrioma, what are the options we have? The first is, of course, cystectomy. Then we have ablations. And the ablation therapies available are laser ablation, plasma energy ablation, combined technique, and also alcohol sclerotherapy. So what I'm going to do is I'm going to show you all these different techniques and then tell you all what is the evidence for changing from our traditional laparoscopic cystectomy to ablative or sclerotherapy, and what is the evidence for these alternative methods. Now, you all know about ovarian endometrioma. I think we all operate on ovarian endometrioma, and this is probably the standard therapy. This is the kind of patients that we see, a patient who has adhesions, rectovaginal deep infiltrative endometriosis. And as I said yesterday, my method of doing endometrioma surgery is to inject diluted vasopressin into an area which I think is below the capsule, and then try to strip the cyst wall as gently as possible. It is important because, and my technique is only, if possible, one puncture to do something called auto dissection by just the saline and the water and the vasopressin, and then try to go and find a correct plane to try to remove the cyst wall as atraumatically as possible. Sometimes the water that we inject may not be in the correct plane. It may be deeper. And so by looking carefully, we may be able to find a thinner layer to remove the cyst wall. So this has to be done slowly, carefully. And here you can see that there is another layer beyond, above the area that I thought was the layer of cyst wall. And so here, the cystectomy is being performed. I'm going to show the whole cyst wall. As I can see here, you can see there is another layer that may contain follicles, and we want to try and get as thin as possible a cyst wall to separate the cyst wall from the ovary. As I will tell you all later that cystectomy is a destructive surgery in the sense that we are actually going to lose follicles when we are doing cystectomy. So being careful and being patient is an important part when we are doing cystectomy. Another recommendation by many people is actually when you come to the hilum, don't tear, just cut, use scissors to cut, because it's probably an area where there's a lot of follicles and we want to spare the follicles. So I think this is something that all of us are doing, and just to reinforce that this is probably the standard technique in many of our patients. And the question now is, why should we go to ablative techniques? This is why I'm going to discuss. So I'm going to show the whole video. So we are going to still continue stripping and taking out the whole cyst wall, as I said, as atraumatically as possible. So that shows the whole cyst. So in this particular case, I did not use a scissors to cut because the cyst wall just came out by itself. Okay, so the cystectomy is done. And again, as I showed you all in the lecture yesterday, that I suture my ovary, and I will also do an ovarian suspension. So here I'm suturing the ovary. And then, as I showed yesterday, I will do an ovarian suspension. Then we proceed on to the ovarian suspension. So this is the standard method. So let's go on to the next method. The next method is laser ablation. Basically, the whole concept is to ablate the cyst wall using different types of lasers. The laser that I'm using now is a diode laser, where you can use any type of laser, but diode laser is good because you can get to all the deep areas, and we want to do it very carefully so that we get as much of the endometrial lining as possible. It is tedious, it takes time to do this laser, and it's also expensive. No, it's not a cheap procedure, but it gives you a good feeling that you actually didn't strip the whole ovary and you have just ablated the cyst wall. So this is laser ablation. Sometimes it can be tricky, but these lasers, sometimes you can turn them and get into difficult areas to ablate the endometrial lining. So this is laser ablation. Okay, so this is done. So if you want to, you can take biopsies, but I think it's probably not necessary. The next one is plasma energy. The principles is the same. Some say that it is slightly cheaper. You have to buy the machine, and it produces a spark that will kill the endometrial lining. This is a paper by Horace Roman, and he said that it is a good method of ablation of the cyst wall, and it gives good fertility rate. We will discuss that a little bit later. So this is plasma jet ablation of the cyst wall. Okay, the next one is a combined technique. This combined technique was actually proposed by Jacques Donnet. We do the cystectomy similarly, but what we will do is we will leave a certain portion of the cyst wall at the hilum, and then the cyst wall is taken, and this area that we didn't remove will be ablated using a laser. Here I'm using a carbon dioxide laser. This was a trend about 15, 20 years ago when he first published his paper. So this is a combined technique. Okay, so we ablate the area that is near the hilum so that you don't tear that area. Okay, the next one is sclerotherapy. Now, sclerotherapy is a technique whereby you put in alcohol, and this alcohol is 95% and above, 100% alcohol, into the ovary so that it kills the cyst wall. So here, this video is from Horace Roman, and it was published in JMIC, so I took it from there and I got his permission. So this is a traditional cystectomy. When you do a traditional cystectomy and you separate the ovary from the area that it is attached, it will leak. So this is not what you want to do. So what you will do is you will puncture the cyst at the area that is closest to you, and you can puncture with a diathermy needle and then aspirate, or in another way you can do a direct puncture of the cyst, and then what we do is you flush the cyst, remove all the cyst content. So this is what he's doing. So after aspiration, you flush the cyst a few times to make sure all the contents are aspirated, and then you placed alcohol inside the cyst, into the ovary. So he has done that, he's flushed, and then he's putting a catheter. He'll put in a silicone catheter into the cyst. So he's flushing thoroughly the cyst, because we can't see it's inside because it's just a small hole, and then a catheter is placed into the cyst, and then you inflate a balloon so that it doesn't spill to occlude the incision, and then inject alcohol. How much alcohol you inject depends on the size and volume of the cyst. You want to get to about 80% of its volume, and after that, after putting the alcohol in, leave it there for 10 to 15 minutes. On researching for this paper, I realized that there are some people who actually leave it there. It's just left there and they don't take it out. But I think many people will remove the alcohol after about 15 minutes. So he says that at that time while you're waiting, you could do other things like an appendicectomy or do adhesiolysis. And then after 10 to 15 minutes, you remove the cyst wall. You make sure that you wash and remove any alcohol that is spilled in the abdominal cavity. Okay, you have to take you have to excise a little bit of the ovarian tissue at the area where you put in the balloon, because this area will not be affected by the alcohol, and also ablate that part of the cyst wall. So that is alcohol sclerotherapy. So now let's look at the evidence. This is a recommendation by many groups, ASHRI, ESG, the World Endometriosis Society, and their recommendation is that surgical treatment is the mainstay of for endometrioma management when treatment is required. The aim of elimination of endometriotic tissue is to provide sufficient tissue for histological assessment and to preserve a maximum amount of normal tissue where fertility is desired. So this is their recommendation. And however, in the same paper, they say that it has been shown that surgical treatment of endometriotic cyst is associated with an unintentional removal or destruction of ovarian follicles, which can be objectified by a measurable post-operative reduction in serum AMH or antral follicle count. So that they are very sure. I think we are all also aware that when we do a cystectomy, we are going to remove some ovarian tissue, and so the AMH will reduce. This is the old Cochrane's study, and they also said that if you do ablative treatment, you have higher recurrence, lower pregnancy rate, and lower AMH. Then so why are we doing ablative therapy? So this is a recent review on ablation and sclerotherapy, and they have objectively reviewed what is the current. This is the latest one that I could get is 2021. And so I'm going to look at this paper and give you some evidence of cystectomy versus ablation, cystectomy versus sclerotherapy in terms of reduction in AMH, recurrence of endometrioma, and pregnancy rate. These are three things that we want to know. Is where does ablative therapy falls in patients with endometrioma? So the first is cystectomy versus ablation in terms of reduction of AMH. And they found 5 studies, and the 5 studies indicate that both ablation and cystectomy have negative impact on ovarian reserve. However, smaller decrements of serum AMH level after ablation were uniformly reported. Ablation appears to be advantageous in terms of preservation of ovarian reserve, especially in women above 5 centimeter size or bilateral lesion. So what they're saying is that they have enough evidence from these 5 studies to say that your AMH will actually become lesser, will reduce, but not as much as that if you do a cystectomy. So this is the evidence. If you do ablation, not sclerotherapy, but ablation. Ablation meaning laser or using plasma jet. What about cystectomy versus ablation in recurrence? There are 7 studies compared the recurrence rate of endometrioma between ablation versus cystectomy. Interestingly, 5 studies reported a higher recurrence rate in ablation group than in cystectomy group, but without a statistical significance difference. In the randomized study by this person, he reported that a significantly higher recurrence rate at 1 year follow-up with ablation group compared to the cystectomy group. However, the recurrence rate after 5 is similar. So generally, the consensus is if you do an ablation, you have to tell your patient that the recurrence rate will be higher. This we need to understand. And which is more important is the pregnancy rate. 5 studies reported pregnancy rate after ablation versus cystectomy. These are the 5. It shows that there is a reduced pregnancy in ablation, there's reduced pregnancy in ablation versus cystectomy, and similar pregnancy in ablation versus cystectomy. So actually, surprisingly, I was also surprised that actually there are 2 studies that say that actually pregnancy rates were reduced with ablation compared to cystectomy, even though the reduction in AMH was lesser in the ablation group compared to cystectomy. So this is confusing. So why are we doing ablation when your pregnancy rate is low, although the AMH level is not that reduced? So this is a bit puzzling. So let's look at sclerotherapy. In sclerotherapy, there are only 2 studies, and in one study, when looking at reduction in AMH, it says that the AMH is similar between sclerotherapy for sclerotherapy and cystectomy. And in one study, it says that the AMH reduction is more with cystectomy, but there's no reduction in AMH with sclerotherapy. So this is for AMH, ovarian reserve. As for recurrence, there are 4 studies, and these 3 studies show that the recurrence rate is similar between sclerotherapy and cystectomy, whereas it's higher in sclerotherapy compared to cystectomy. And when we look at pregnancy rate, 2 studies describe a similar spontaneous pregnancy rate between sclerotherapy and cystectomy. Whereas in IVF, for recurrent endometrioma, sclerotherapy may be more beneficial than cystectomy. In another 2 studies for recurrent endometrioma, sclerotherapy may not be more beneficial than sclerotherapy. And in one study for endometrioma, sclerotherapy may be more beneficial than sclerotherapy in terms of cumulative live birth rate. So again, the data is very, very confusing. So we don't know whether actually sclerotherapy will give you a better pregnancy rate after IVF or even spontaneous pregnancy. So what is the conclusion from this paper? Both ablation and cystectomy have negative impact on ovarian reserve, but ablation results is smaller AMH decrement than cystectomy. That means you have a lesser reduction in the AMH level if you do ablation compared to cystectomy. So ablation is recommended in terms of ovarian reserve. However, ablation tends to result in higher recurrence than cystectomy. In the past, ablation has been reported to be disadvantageous in terms of pregnancy rate in comparison to cystectomy. However, several recent reports present a similar pregnancy rate between the 2 groups. So this is for ablation. As for sclerotherapy, it remains inconclusive whether sclerotherapy is better than cystectomy in terms of ovarian reserve. The recurrence rate appears to be similar after sclerotherapy and cystectomy. There's no concrete evidence that sclerotherapy helps to improve IVF pregnancy rate when compared to cystectomy or no sclerotherapy. In the author's opinion, sclerotherapy should apply carefully only to recurrent endometrioma when it would be difficult to perform cystectomy and ablation. I hope I've not thoroughly confused you all. So I will tell you what my take in this situation. So basically, we see 3 groups of patients with endometrioma. We see the young girl with endometrioma, and in this kind of patient, a young girl or an unmarried girl with endometrioma, in this kind of patient, my policy is to actually defer surgery as long as possible until they get married. This is my policy. Unless the cyst is so big or very symptomatic, I will not do surgery. Then the second group of patients are the patients who got married and have endometrioma and cannot get pregnant. So in these patients, I would prefer to do IVF because I think we will overcome all these problems of a reduction in ovarian reserve if we can do IVF. But unfortunately, many patients say, I don't want, I want to try and get pregnant on my own. Then I would do an AMH as a prophylactic measure to know what the status of the patient's fertility is. This is more 2 reasons. One, to protect myself, that later when the patient goes to see somebody else to do IVF and the AMH is low, she will not blame my surgery for the low AMH. This is the first point. The second point is I will always tell the options of ablative surgery, because in this now litigators world, we have 2 options, and she will tell me, why didn't you tell me that there is something called ablation and you didn't tell me about laser ablation or sclerotherapy? So I'll tell her that these 2 options are available. If her AMH is good, then I would recommend her. Of course, the patient will ask you, what do you think, doctor? I will recommend a cystectomy because I think that is good option for her. But if her AMH is low, then I will offer her ablative therapy. And the preferred ablative therapy is laser now. instead of sclerotherapy. And then the third group of patients are the patients who have recurrent endometrioma. So they have had a surgery before and they come back with cyst wall. And again, I will do an AMH. And if the AMH is low, which frequently happens to be low, I would tell them ablation may be a better option for them than doing a cystectomy. So this is the current scenario in which I use ablative therapy as opposed to a cystectomy for endometrioma. Thank you.
Thank you, Dr. Selva, for the balanced and insightful session.